Hello everyone, my name is Christoph Correll. I'm Professor of Psychiatry and Molecular Medicine at the Zucker School of Medicine at Hofstra, Northwell in New York, and also Professor of Child and Adolescent Psychiatry, Charité University Medicine in Berlin. Welcome to this presentation titled Cariprazine, Translating Clinical Data into Clinical Practice. Before we start, I just want to remind us why this is a virtual talk, obviously because of the pandemic. And I want you all to please participate and send on the link to participate in what we believe is the worldwide largest study on the physical and mental effects of the pandemic across the globe. More than 155 countries have participated, more than 167,000 people. The COVID study, www.cohfit.com. Please participate. But this talk is about translating the cariprazine data into your clinical care. Let me start with my disclosure information that you see here. Today's program is sponsored by Hikma Pharmaceuticals, but you will hopefully see that this is a fair and balanced presentation of the data that are out there. What do I want to cover with you? First, what's the pharmacology of cariprazine? The short and long-term efficacy as well as safety data. Specifically, what are the data on the treatment of negative symptoms, an area that is hard to treat in schizophrenia, and then we'll finish up with some case presentations and conclusions. Let's start with the pharmacology. First of all, the pharmacokinetics, meaning what does the body do to the drug? And what's important there for us to dose and know where steady state of the dose and level occurs is the half-life. Cariprazine is broken down into desmethyl and didesmethyl cariprazine. Desmethyl cariprazine has a shorter half-life than cariprazine. It's the bottom line. But didesmethyl cariprazine actually has a very long half-life. Taken together, cariprazine and its active metabolites have a 1-week half-life. That is very beneficial when patients stop a dose, hold it, have a drug holiday over the weekend. This medication is very forgiving. It balances out these forgetting doses or also gaps. In effect, even though this has not been tested in trials, if you have given 5 weeks of daily medication, you could potentially, based on the PK data, give the medication once or twice a week, supervised intake, and still hold the level. But obviously, you also will need some more time to build up the level. So it takes 5 weeks, 5 half-lives for full steady state. But don't be fooled to believe that this means it takes many weeks to get to an effective level. So let's look at 1 week data. At 1 week, we're already at 60 nanograms per deciliter, which is 50% of the steady state. At 2 weeks, we're almost at 100, which is 80%. So we will get to a therapeutic level within 1 to 2 weeks. And if you dose and titrate more aggressively, even faster. In the studies, the dosing was quite aggressive, going up 1.5 milligrams day 1, 3 day 2, 4.5 day 3, 6 milligrams day 4. This is not what we necessarily need to do unless you're in an acute setting and you want immediate efficacy. I titrate maybe every 2 days in an acute setting and once a week in an outpatient setting, because 1.5 milligrams is already as a starting dose an effective dose. But obviously, you want to maybe load in order to get to a quicker blood level in an inpatient setting. But you can also add benzodiazepines to get combined efficacy. What about the pharmacodynamics? This is what the drug does to the brain. Here, we need to consider the Ki, the constant of inhibition values, meaning how much nanomolar concentration is needed until 50% of a receptor is occupied, meaning lower number, tighter binding, because less concentration needed to occupy 50% of the receptor. And what you can see with the 3 partial agonist, ABC, aripiprazole, brexpiprazole, cariprazine, all of them have very sub-nanomolar, below 1 nanomolar concentration affinity for the D2 receptor, very tight binding. That's important because they also deliver partial agonism. But what stands out for cariprazine is that the D3 receptor is occupied at an even more tighter binding and very powerful binding. And that may be relevant for the efficacy I'll describe later for negative symptoms, because when you partially agonize or antagonize the D3 receptor in the prefrontal lobe, there is some increase in dopamine, where we have too little dopamine in people with schizophrenia, resulting in cognitive deficits, negative symptoms, and maybe also some other depressive symptoms. So what is the short-term efficacy in schizophrenia for cariprazine? Here, the 3 pivotal trials, and you can see in a dose-dependent fashion, and every dose that was tested, cariprazine was superior to placebo. Generally, 1 in 3 trials fail, 1 in 3 doses fail. But here, whether it's 1.5, 3, or 4.5 milligrams in one study, 3 or 6 milligrams, or a dose range between 3 and 6 and 6 to 9, with approval being only granted to 6 milligrams because there was no additional benefit of 9 milligrams, you can see superiority to placebo. Aripiprazole 10 milligrams was an active control in one study, and risperidone 4 milligrams in another, and relatively similar outcomes here. But it's remarkable that with cariprazine, the delta from baseline was 20 points up to maybe 26 points. When looking at effect sizes, and that's always the last row in each of those subsections, we can see that actually 4.5 milligrams might be the sweet spot in terms of best efficacy. Remember, 0.2, like a fifth of the standard deviation, is a small effect size. 0.5 is a medium effect size, and 0.8, a large effect size. This is not from baseline. This is versus placebo. So you add the placebo effect and you get large effect sizes anyway, what we see, what the patient experiences, what the family sees too. But let's look at the different subscores. The total score, 0.5 effect size for the 4.5 milligrams, and about 0.4-ish for the others. Negative symptoms, even 0.6 for the negative symptom improvement effect size for the 4.5 milligrams, and 0.3 to 0.5 with the other doses. Positive symptoms, again, the 4.5 milligrams seems to stand out. Same for disorganized thought. There were very few uncontrolled hostility and excitement symptoms because patients had to sign a consent. So here, even relatively similar efficacy. And patients were not selected for anxiety or depression. So the effect size is smaller because there was less to treat. But cariprazine is approved in the United States for mania and bipolar depression because the partial agonism seems to also confer effect for depression. What is the long-term efficacy? Here, a relapse prevention study. Patients stabilized on cariprazine, 3 to 6 milligrams, and then continued on cariprazine, and you can see that there's a significantly lower relapse compared to placebo when the medication is stopped, with a hazard ratio of 0.4, a 60% risk reduction of relapse when continuing cariprazine, which is a very strong effect, and having only around 20% relapse in the drug arm is very low for a full year. Here we did a study comparing indirectly the results of different studies that have relapse prevention data, stabilizing the drug, the patient with the oral medication, and then stopping it or continuing. And here we're just looking at the placebo arm, and we plotted on the x-axis the duration of the half-life, and on the y-axis the placebo relapse. So how long does it take until you have relapse when stopping the medication? And on the top panel, it is at 4 weeks, the relapse. And you can see that there is a relationship. The shorter the half-life, the higher the relapse rates at 4 weeks, and the lowest relapse rate with cariprazine, followed by brexpiprazole, which has a 3-day half-life, with cariprazine a 7-day half-life. Let's flip it around and now look at panel B and C, where we now ask about a 5% greater placebo relapse than drug, and on C, a 10% greater relapse. And you can see that, again, it takes the longest for cariprazine, 6 and even 12 weeks to have 5 or 10% more relapses after stopping the drug compared to continuing the drug, meaning there is still medication available that covers the patient while the medication has been stopped, giving us more of a window of opportunity to bring them back, to continue the treatment, but also leveraging out when patients have stopped intermittent taking. But we are not only looking at relapse, we're also interested in remission. And remission is a 6-month time period of no more than mild positive, 4 of them, and mild negative symptoms, also 4 of them. And you can see that with cariprazine, around 50% of patients are only mildly ill, both in positive and negative symptoms throughout this relapse prevention study. The number needed to treat of 6 or 7 is clinically and significantly statistically relevant, because any NNT number needed to treat below 10 is considered relevant. But what about safety? Here we see that, again, the 4.5 milligram dose seems to stand out in having less patients discontinue, but the discontinuation, even with the other doses, was not much different from placebo. Looking at reasons for discontinuation, very few people actually discontinue with side effects, less than 10% in the 4.5 milligrams. Other reasons, insufficient therapeutic response, again, below 10%. But what were the side effects? Very few serious adverse effects. There was akathisia, but that had to do with the aggressive dosing. So starting at 1.5 and not going daily up by 1.5 milligrams in my clinical use and care, definitely, and also in other open label data, reduces the risk of both EPS and akathisia. There is pseudoakathisia with aggressive dosing. You can do it quickly, but provide a benzodiazepine, which brings that restlessness down. Other than that, no side effect really that is relevantly greater than on placebo, and around 5 or 6%. Let's look at akathisia events. They were mostly mild and moderate, very few were severe, and very few people discontinued for the restlessness. Akathisia could be treated with anti-EPS medication, which is not ideal, but often patients had also extrapyramidal symptoms. I think the weighting approach is better. Here we see that 94%, 93% actually had resolved akathisia after just holding the dose or going 1 step down. Akathisia resulting in discontinuation was very rare, only about 6% and 2% more than on placebo. Another advantage of cariprazine in the short and long-term data is that it has relatively few cardiometabolic risks, very little weight gain, and with that also very little effect on the lipids and glucose. So body weight gain was around 1 kilogram or less in most doses, and that was maybe 0.8 kilograms more than on placebo. Very favorable. Also, the QTC interval doesn't prolong much. It actually might go down a little bit. What about negative symptoms then? Negative symptoms are very hard to treat, and there was a dedicated study comparing cariprazine 4.5 milligrams with risperidone 4 milligrams in adults aged 18 to 65 who had schizophrenia for at least 2 years. They were stable for 6 months and had predominant negative symptoms, meaning more negative symptoms than positive symptoms, relatively few positive symptoms. Also, since improvement of positive symptoms can look like improvement of secondary negative symptoms, people being less suspicious, more outgoing when the voices go down, other confounders could be depression that improves. But here, patients couldn't have much depression, or differences in extrapyramidal side effects. There were no differences in EPS, depression ratings, and improvement in positive symptoms in these stable patients in the risperidone or cariprazine dose arm. But there was a difference in the primary outcome, and that was the PANSS negative symptom factor scale. The difference occurring at 14 weeks out of the 6-month study, which makes the difference greater over time. The question then is, this point difference, does it matter for patients? And there are two ways of looking at it. One is responder status, which was also better with cariprazine than with the risperidone. But the next one is, does it matter for patients? And here functioning is relevant. And using the PSP, the Personal and Social Performance Scale, cariprazine was associated with an even earlier than 14, that's 10-week separation from risperidone, and in the 3 areas that matter. Patients were not much aggressive or disturbed because they were stable, but social useful activities, personal social relationships, and self-care all favored cariprazine in a significant way. Let's move now to the final part, and that's translating the data that you just saw into real-world cases. And I picked 3 cases that are paradigmatic of where you might want to try cariprazine first. The first one is an acutely exacerbated patient with schizophrenia in an early phase of the illness, where patients arguably have the most to gain and the most to lose. 22-year-old second-generation Indian male in college, living at home, who was brought to the emergency department by the mother after a first relapse 6 months after the first episode. He stopped olanzapine, 10 milligrams, that he responded to due to feeling in a brain fog and gaining weight. He's presenting to the ER, moderately agitated, pacing, and being suspicious. As per the mother, he has not been himself for the past 6 weeks, not hanging out with friends anymore, seemingly under pressure. Insomnia, holding his head, sniffing at and eating food only alone in his room, maybe out of fear to being poisoned, and gesturing to self, sometimes being incoherent. There's a family history of panic disorder, depression, and substance use, and he admits to occasional marijuana use. So in this case, we felt we wanted a drug that's helpful, but doesn't cause the brain fog, not too much sedation, and doesn't give him the weight gain he didn't like. We started at cariprazine 1.5 as per package insert and the trials that had been conducted. But the patient was upset to be in the unit again. He was afraid of the chronic patients. And 1.5 milligrams is just a starting dose. So we supplemented this with the lorazepam, 1 milligram 3 times a day. On day 3, not pacing anymore, still tense and suspicious, vaguely talking about them wanting to do something to him, disclosing some initial paranoid delusion. Not on day 2, but on day 3, we went up to cariprazine 3 milligrams and were able to reduce the lorazepam to twice a day. At day 7, visibly more relaxed, opening up now about hearing voices, less intensely and paranoid plot that he felt was planned against him by schoolmates. On day 10, we went further down on the lorazepam. We kept the cariprazine 3 milligrams. He's a first episode patient, or second episode now, but very early in the disease course. And he responded to 10 milligrams of olanzapine. We don't most likely have to go up. After stopping the lorazepam, there was an initial insomnia episode, but that was covered with zolpidem for a week, and then it could be stopped safely. He was discharged into outpatient care after 3 weeks. Otherwise well tolerated the medication, no daytime sedation or residual insomnia, some increase in appetite, but no more than 1 kilogram weight gain at 6 weeks, and didn't have EPS or akathisia because I think we went a little bit slower and we covered him during the initial phase when the brain gets used to the partial agonism with a benzodiazepine. Second case, a worsening outpatient, 33-year-old male, paranoid schizophrenia since age 18, some alcohol abuse since age 22, not doing very well overall, living in a residential home, mostly keeping to himself. He had multiple psychiatric hospitalizations, some due to non-adherence, some reportedly due to breakthrough psychosis, but the full adherence wasn't always clear. He has been on risperidone 4 milligrams, but also has obsessive compulsive disorder and received sertraline 250 milligrams. Now he had a life event, a change in his roommate, who he feels is somewhat messy and can't really be trusted. There's unclear adherence, but an increase in his suspiciousness towards the roommate and worsening from occasional whispers and noises to several male voices telling the patient that the roommate actually is the devil. Also, to cope with this, he had some increase in rituals. There's some doubt about the paranoid ideas that can be elicited, but he's visibly uncomfortable and distressed. So he's brought in by the guidance counselor of the group home, and upon further questioning, he admits to having half the risperidone dose from 4 to 2, some days even skipping it altogether because he did not like the reduction in libido and the erectile dysfunction. Here, a switch to cariprazine is discussed to normalize the prolactin level and maybe even improve some of his seclusive existence in the group home. The plan is discussed with him and the guidance counselor. The patient didn't want to be admitted, so we needed to make sure that he was safe, and the guidance counselor kept an eye on him. We continued the risperidone too, but started cariprazine at 1.5 milligrams for 7 days. We have some more time. We don't want to rush it and give him bad side effects. A week later, he's seen he's less distressed, the voice is less intense and frequent. We increase cariprazine to 3 milligrams. A week later again, he's seen and he only hears voices occasionally during the day. We didn't touch the risperidone yet. We added the partial agonist to the ongoing risperidone. The symmetry rituals are down to 10 minutes, and he's less upset by the roommate, but developed some mild tremor, yet improved libido. So we now decreased the risperidone to 1 milligram, and a week later, stopped it entirely. And then we increased the cariprazine to 4.5 milligrams, thinking this is a chronic patient. He needed 4 milligrams of risperidone. So the equivalent most likely is a 4.5 milligram dose. We're able to then stop the risperidone a week later. The OCD further improved, and he did not have any relevant auditory hallucinations. But what was noted, he was more interactive in the group home, not only with the group, the roommate, but also other members of that society. Finally, a switch for intolerability. This is a 40-year-old female with schizophrenia since age 27. She underwent multiple hospitalizations, especially early in the illness in the first 6 years, and unfortunately had even 2 suicide attempts with pills. Therefore, she was started on quetiapine because that was felt to maybe also help her intermittent depression. Stabilized in the last 5 years on 600 milligrams of extended release quetiapine plus fluoxetine 20 because she was also seen to have social anxiety. She lives with a very involved in her care mother who is 76 years old, but has relevant negative symptoms, anhedonic, social withdrawal, doesn't do much with her day. Very upsetting to the mother. Weight gain has been a real problem due to prior antipsychotics, risperidone and olanzapine, but also with the quetiapine. She now has obesity and metabolic syndrome, which further concerns the mother. So here again, a switch to cariprazine is discussed and finally agreed with patient and mother with the idea to really not worsen a potential suicidality or depression because of the partial agonism of cariprazine, reducing the weight, and maybe helping with the negative symptoms that have been quite enduring. We started at 1.5 milligrams of cariprazine for a week. Didn't touch the quetiapine yet. We don't want a rebound from stopping a sedating medication. Going up to 3 milligrams a week later. Then going slowly down from quetiapine 600 to 400. Waiting 2 weeks so that cariprazine can really build up and that the brain gets used to the lower quetiapine dose. So a month into the titration, increasing cariprazine to 4.5, thinking again that might be the sweet spot. Waiting 2 weeks and only then going down from 400 to 200 milligrams of quetiapine. She's tolerating that switch really without any changes noticed. Again, another 2 weeks later, we discontinued quetiapine, and as we can sometimes see when people stop quetiapine, that is sedating and can help sleep architecture, there was some mild insomnia for 2 weeks, again, covered with zolpidem that could easily be stopped 2 weeks later. So 3 months into this plateau cross-titration, adding cariprazine to ongoing quetiapine and then slowly going down, she actually had already lost 3 kilograms and improved some of her metabolic parameters. But what the mother was most delighted by was that she had less anhedonia. She was more willing to perform chores in the house and even went out with the mother. That was a very important event. She went even into a larger shopping mall to buy some clothes, which had not occurred in many years. So what are then suggested real-world patients for cariprazine? Early phase patients who respond well, but who also need to function well. Younger patients, and those that respond to other antipsychotics where there might be some need to improve the outcome on side effects or also on negative symptoms. Patients who are either adherent to antipsychotics and don't need an LAI, a long-acting injectable, or those that actually should be on some non-adherence covering medication but refuse an LAI. And here we have an extended dosing opportunity for the long half-life cariprazine, which would have to be given supervised for 5 weeks to get to steady state, maybe 4 weeks. And then even when only supervision once a week can take place, there should still be very good coverage. Residual negative or depressive symptoms might again prompt cariprazine consideration. And side effects, sedation, cardiometabolic, prolactin and sexual dysfunction, where cariprazine is very clean in most patients. And clearly a focus on improved functioning and quality of life. Just a final note on D2, D3 partial agonists, which cariprazine is. So a partial dopamine agonist is not just a me-too D2 antipsychotic. The partial agonism hits receptors that are not prepared for this initially. So a dose that's too high initially can lead to pseudoakathisia, a restlessness until the dopamine receptors accommodate the partial agonism. On the flip side, too abrupt switching from a full D2 agonist, where the dopamine receptors are blocked and hungry, upregulated, and then the partial agonism can hit those upregulated receptors, can lead to rebound phenomena like restlessness, akathisia, or even worsening of psychosis, which is a drug-drug interaction rather than lack of efficacy of the partial agonist. Similarly, switching from a pene, which is a sedating drug, olanzapine, quetiapine, chlorpromazine, here we can get a rebound due to histaminergic efficacy or hitting the receptor that is upregulated. And that can be looking like rebound anxiety, insomnia, restlessness, and akathisia. Similarly, going from shorter to a longer half-life drug, and cariprazine has the longest half-life, if you switch from a PIP to a PIP, not a problem. You can do a cross-titration. Aripiprazole, brexpiprazole to cariprazine, no problem, same to same. But if you go from a shorter half-life drug, which is all other antipsychotics, then you need to overlap to not have too little dopamine blockade. So the plateau cross-titration is the most effective strategy. But if you have to go fast, use a benzodiazepine. Clearly, when you don't have enough dopamine blockade, a higher dose of a partial agonist gives you higher antipsychotic effect due to more functional dopamine blockade. So let me thank you for your attention. Again, ask you to please participate in the COFIT study, www.cofit.com, and I look forward to receiving your questions during the Q&A session.